Good afternoon, all of you. I'm Dr. Vishal. I'm practicing as consultant pulmonologist at KIMS Hospital, Secunderabad. So today is World Sleep Day. So I'm here to enlighten and all of you regarding important condition, where there is almost very less awareness compared to other diseases which we all know. That is obstructive sleep apnea. The moment I tell that it's obstructive sleep apnea, so how many of the viewers or from the non-doctor groups know about this condition? Why I am insisting about awareness is many a times every day we encounter these patients in OPD, not just in pulmonology OPD, but these patients always land up in neurology OPDs, cardiology OPD, endocrine, psychiatry, ENT OPDs, internal medicine, and these are all the commonest OPDs where these patients actually land up because of the complications of this disease in those respective systems, which I'll be telling about all of that to you. And then eventually they suspect that probably the patient has obstructive sleep apnea, and then they refer to a pulmonologist for a test called as sleep study, which we use it to diagnose this condition. I repeat, it is called as obstructive sleep apnea. Wow, the name itself tells that it is a condition which is occurring in sleep, and it is obstructive. That means the flow of air is being obstructed. The flow of air, the breathing in the sleep is obstructed. And then the patient is choking. Choking in the sense is not actually breathing. That is called as apnea. So shortcut is OSA and the full form is obstructive sleep apnea. What are the symptoms and why does this obstructive sleep apnea occur? The commonest symptom which we look for in the patients of obstructive sleep apnea is snoring. The sound which the patients make while breathing in sleep, which we all have some patients at home who actually snore. Telugulo guraka antaru, Hindilo karate antaru. So this is almost more than 90% of the patients have severe snoring in those patients having OSA. And the second most commonest symptom is excessive daytime sleepiness. Patients sleep excessively during the day, which is very unusual. Even after having almost 8 to 10 hours of sleep also, they don't wake up fresh and they again tend to doze off wherever they are, be it be in the office, be it be in the car, and even we have patients while sleep who while driving and they make accidents. So daytime sleepiness is also equally important compared to snoring. These two are the cardinal symptoms, what we call as obstructive sleep apnea. What are all the other symptoms which can be there or other signs which can be there with obstructive sleep apnea? Patients can have nocturia. Patients wake up often to pass urine, sometimes 3 times, 4 times. In addition to diabetes or prostate issues, obstructive sleep apnea is also one of the cause of nocturia. Patients can have forgetfulness, matimarupantaru, and excessive weight gain in the last few months or a year. They suddenly jump their weight by 10 kgs, 15 kgs. And patients can have a lot of other symptoms like early morning headache or headache lasting all through the day. And OSA headache is one of the diagnoses where the neurologist considers in every patient walking with headache. And other complaints like patient can have refractory hypertension. Even though the patient is using multiple BP medications, their BP is not under control. And patients can have diabetes which is usually controlled, but suddenly because of OSA, despite many medications, their diabetes is poorly controlled. and that is where they visit their endocrinologist or a diabetologist. That's where the patients can end up getting tested for a sleep study. So patients can have multiple psychiatric symptoms, like they can also have anxiety, they can also have depression. So a lot of psychiatric symptoms are also being are also there in obstructive sleep apnea. Even eye complaints, eye ophthalmology symptoms can also be there. It can disturb glaucoma, and there can be poor control of glaucoma in OSA patients, and OSA and eye is also related. So, on an average, there can be 9 different system-based symptoms for these patients, and all these patients can go into these 9 different OPDs before getting diagnosed with obstructive sleep apnea. So, what happens and what exactly happens, and how is it affecting the body? So there can be multiple reasons why we are snoring. We see a lot of snoring patients who are obese and having a lot of neck circumference, double chin. So these are the patients who have snoring and excessive snoring. And there are some anatomical reasons also, like in children, it can be adenoids and tonsillar enlargement causing lack of space in the throat for a comfortable breathing in the sleep. That's where children snore, and they also can be affected with sleep apnea, and their air airflow is not optimum because of this adenoids and tonsillitis, and that's where they can be referred for adenotonsillectomy also to have a complete reversal of sleep apnea. There are anatomical reasons also, like somebody is having a retrognathia or micrognathia. If the jaw is small, or if the jaw is uh, little to the back compared to your mouth, normally it should be in the same plane. So this is called retrognathia or micrognathia. These patients, even though they are not obese, they can have severe snoring and they can be affected with obstructive sleep. So apart from these anatomical factors, there are just some people having loss of muscle tone in the sleep is usually less compared to when we are in a wakeful state. In some people, it is the loss of muscle tone of the pharynx and the neck muscles are relaxed very much, where they are unable to hold the space in the throat behind the tongue, and that space usually collapses and cause severe snoring. So these are all the reasons why somebody snores and they can be affected by this condition. And when the airflow, because of snoring, the breathing is really hampered because it is getting obstructed either in the nose or in the posterior side of the nose called nasopharynx, or in the oropharynx, or that is in the throat. And there is the when the airflow reduces, even the oxygen percentage in the blood goes down. It can vary from few percentage of SpO2 drop to even significant 40-50% of droppage also. Not always the patient needs to choke. That is apnea. Many a times patients can have just hypopnea. Hypopnea is just a reduction of the flow, leading to some at least 4% of decrease in the SpO2 in the blood. This is called hypopnea. So these things, by reducing the oxygen in the blood, and this phenomena is happening repeatedly in an hour or in a night, which can cause lot of sympathetic drive, sympathetic stress in the body, can lead to a lot of changes in the body, leading to all these complications like refractory hypertension or diabetes, even metabolic syndrome, and excessive weight gain. And again, this is a cycle. Once a patient gains weight, again the snoring increases, and again it increases weight. So we need to break the cycle at some point of time. So this is how the sleep is affected by repeated drop in the oxygen because of lack of airflow. The brain doesn't go into deep sleep. There are what we call it as a 4 stages of sleep: N1, N2, N3, and the REM sleep. REM sleep is a rapid eye movement sleep where we dream, and this REM sleep happens every 90 to 120 minutes in the night. So REM sleep is equally important than the non-REM sleep to have a proper rest in the sleep. So when the REM sleep is compromised, even before the patient is going into REM sleep, the sleep is disturbed because of the choking, and the brain is stimulated. So they again come back to lighter phase of sleep. So these patients always complain that they never had a adequate sleep, though they are sleeping adequately based on the hours of duration. So if we see these patients' sleep study reports, they almost spend 90% of the sleep in only lighter sleep, only the N1 and N2. N3 and REM sleep is significantly compromised. Usually REM sleep should be 20 to 30, 20%, 15 to 20%. We only see a 2.5% or 5% of REM sleep. Hence, the patient is really not resting in the sleep, and this is leading to a constant stress in the body and leading to a lot of complications. So this is how sleep apnea can affect your body by repeated drop in oxygen levels due to blockage of air in the throat, and the significant symptom is, I repeat that, it is snoring, and we have simple snoring to severe snoring as a grades of snoring. So what do we do? And when a patient comes with these symptoms, be it be the patients can directly have a consultation with us thinking that they are snoring severely and they are sleeping in the office, in the chair or in the car. Yeah, so if they are aware of this condition, they usually come to us. Or they are usually referred by a cardiologist or a neurologist or endocrinologist. As I mentioned already, what were the symptoms, they come and with a suspicion of obstructive sleep apnea. So we usually do this sleep study. It's there are four levels of sleep study. That's called level 1, level 2, level 3, and level 4. The commonest one we do is a level 1 or a level 2. A level 2 study can be done at the home also. Only difference is the level 1 has a video monitoring, uh, where we also look for some other conditions, especially which the neurologist requires. So what do we do in this sleep study? We ask the patient to come to the sleep lab, and we create an ambience in the lab as if it's like his home, and we connect a lot of leads to his head which calculate the EEG, and we connect sensors which can detect snoring, which can detect the oxygen flow of air through the nose. We also have a pulse oximeter, oximetry. We attach one oximeter. We attach ECG leads, and we attach EOG, eye movement leads, and we also attach EMG leads on the legs. And we have two belts, one on the chest and one on the abdomen. Why we need all this is, we need to know whether the patient is sleeping by EEG, in which stage of the sleep the patient is, and at what stage of the sleep, how much is the snoring, and is the snoring reflecting into oxygen percentage? Is the snoring really blocking his flow of air, and which is again leading to oximetry? And we correlate those things with the chest and the belt movements also. If the chest and belt movements are significantly higher compared to the normal, we feel that the patient is choking and the chest and abdomen are trying to open up the throat. So this phenomena we try to recognize by looking at the graphs on this polysomnogram, which we call as a sleep study. And we have sleep scorers which has calculate these number of events. And the number of events in the whole night is usually divided by the number of hours the patient slept, actual sleep, not the time he went to the bed, because we only calculate the time of sleep by EEG leads. So minimum efficiency of sleep, we look at these reports is at least 80%. The patient should be sleeping. So this index is called as an AHI, apnea hypopnea index. How many times the patient is choking every hour. If it is less than 5, we take it as a normal. If it is a more than 5, the patient is labeled as a patient of obstructive sleep apnea. And we have a grading, like if it is 5 to 15, it's mild, 15 to 30 is moderate, and more than 15 is severe sleep apnea. So when a patient gets diagnosed with sleep apnea, the first thing we we look for is any reversible factors are there. Suppose if we can reverse them, maybe his snoring comes down, and he can be cured of sleep apnea. One thing is we do a ENT examination. We check for any if it's a pediatric, we check for adenoids, and if it's adult patient also, we check for DNS, sinusitis, turbinate hypertrophy, and any throat complaints or anatomical factors. Just I mentioned the retrognathia, which can be corrected. So if at all these correctable factors are there, and including hypothyroidism, which adds a lot of neck soft tissue to increase the sleep snoring, we first try to correct them. And if it's a mild sleep apnea, we usually ask the patient to have any lifestyle modifications, especially to reduce the weight. And if the patient is smoking or having alcohol on a regular basis, we ask him to cut down that, even caffeine. These things can worsen sleep apnea. And we ask the patient to have a sleep hygiene, like maintaining a strict sleep timings and room environment to go into sleep and wake up at the regular time every day. And we encourage the patient to sleep in the lateral positions. Like when patients sleep in the lateral position, they usually have less snoring. As you must have heard, if those who are watching, if you have snoring, you must have got this advice from even from your elder people at home, your home. So sleeping on the lateral side will reduce the snoring, and there are a lot of gadgets available like belts or collars where there is a posterior at the back there is some foam ball, and as soon as the patient tries to sleep in the supine position, they are irritated and they go back to the lateral position. So this is how we approach a patient as soon as they get diagnosed, and if it's a mild category, lifestyle modifications is what we advise the patient. If the patient is unable to lose the weight or if he is significantly obese, and there are other options like using a oral appliance. There are some oral appliances like mandibular advancement device where the dentist can usually give this device, and what that does is it pushes the mandible in the forward direction, and posteriorly behind the tongue there is space and patients can breathe without snoring, and they will not choke. But if all this is not possible and there is moderate to severe sleep apnea, we don't consider these options. These are usually adjunctive options for them. What we give them is a CPAP machine with a mask. CPAP is what we call it as continuous positive airway pressure. So there is a small machine which is about this much size, and this is connected to a mask which is over on the face, and this machine and the mask is connected with a 22 mm tube. Once we wear this mask and switch on this machine, what the machine does is continuously pushes air into the throat, thereby giving a pneumatic splint. By just like how an analogy is like how we keep balloons or tires by inflating them with air, like creating some pressure. This machine also creates a continuous positive airway pressure to keep this space open, and the patient breathes comfortably without snoring and he does not choke. So CPAP is the worldwide recognized treatment modality, in the first choice of treatment modality for most of the obstructive sleep apnea patients. If the patient is asymptomatic and that and he's having OSA, we usually consider lifestyle modifications only. But if the patient is symptomatic, irrespective of the severity of OSA, CPAP is what is the treatment modality. And we have multiple modes of pushing these pressures into the patient. Like we have an automatic adjustable APAP where we don't have to tighten any pressure. The machine itself automatically adjusts the pressures what the patient needs, because the machine has sensors where it detects how the patient is breathing. And if he needs more pressure, it will increase the pressure on its own, and it will APAP modes will give the most comfortable pressure and the least pressure which is sufficient for the patient's airway to be open. And the patient needs to use this mask all through the night during the sleep, and he can disconnect it when he wants to get up to have some water or urine, pass urine. So he need not disconnect the mask, he can just disconnect the mask from the tube and then he can use that. And we have multiple other modes, whether if a sleep apnea patient is also having something called as obesity hypoventilation or a COPD condition, We also target something called as a minimum tidal volume. So this is what we as a pulmonologist title and meet the needs of each patient based on the other conditions which the patient has. And what else can we do other than CPAP? And how long do they have to use this CPAP machine? So they need to use this CPAP machine until good recovery and until they lose weight or the snoring is completely reversed. But it usually doesn't happen in few months. The patients need few years to get this result. And minimum we suggest is 6 months to up to 2 years of this CPAP therapy, and try to repeat a sleep study after this if they significantly lose the weight, and if they observe there is no snoring, and we repeat the test and advise them to stop the machine. But if it's a morbidly obese patient where we talk about a body mass index of a BMI more than 35-40, in addition to this, we usually suggest the patient to go for a bariatric surgery, that is a weight loss surgery. By doing the CPAP therapy and weight loss surgery together, there is a optimum result and success of this weight loss surgeries increases. And by 6 months, we see a significant weight reduction if we don't ignore sleep apnea in these patients. What else can we do for these sleep apnea patients in addition to CPAP is we have surgeries which are usually done by ENT surgeons or maxillofacial surgeons, where there are a lot of surgeries which can be done, which can be customized to the patient based on where exactly the air is getting blocked, starting from the nose to the throat. So, ENT evaluation is a must before going for the surgery. There is a test called DISE, DISE, drug induced sleep endoscopy. So, in this DISE, patients are sedated. It's just like an examining your nose until your throat with a camera. They give mild sedation so that you are comfortably sleeping and you start snoring. So while this is happening, the ENT surgeon goes from your nose to the throat and he examines where exactly your air is getting blocked. Sometimes they see that the air is getting blocked in the nose only because of lot of edema, turbinate hypertrophy, and lot of other conditions. Or they might see that you are choking at the level of the nasopharynx or retroglossal or retropalatal area. So based on this area where you are getting blocked, they plan their surgeries. And all the surgeries aim at only one thing, creating space, removing the obstruction, and so that there is a lot of space for the air to go and there is no snoring, and this apnea or choking does not happen. The commonest surgeries that they do is the velopalato-pharyngoplasty, which can be laser assisted also. This is the commonest surgery which is being done, but there are a lot of other surgeries. As I mentioned, based on the DICE report, they usually advise these surgeries. And that can be a very good option for patients who are not who are having multiple reasons where they cannot use a CPAP, or they have failed their therapy on a CPAP, and any other reason why CPAP cannot be used. So surgical modalities have come up a big way, and a lot of these surgeries happening in multiple centers across the country or the world, and patients are having good benefit from these surgeries. So as I mentioned, starting from weight, lifestyle modifications to oral appliances to CPAP therapy, and then surgical modalities, these are all the possible available options for treating sleep apnea. How do we follow up these patients? The follow up is usually in the first month, we ask the patient to come back because these machines store the breathing information within themselves. The machines have a memory card, or the modern machines usually sync with your phone, where with Bluetooth connection you can download the whole data of how you slept the whole night and what was the average AHI and what was the leak, how much was the pressure you were needing to have this sleep apnea reduced. So these are all the data which we call it as a compliance report. So we ask the patient to get this compliance report. We look at the compliance. At least they have to be using for 4 hours a day in this during the sleep with at least 70% of the days of usage. This is what we look for. If that is not happening, we again counsel the patient to increase the usage. We assess and what exactly is going wrong. Is the mask not comfortable? Because there are a lot of other masks, like some masks cover only the nose, some masks cover only nose and the mouth. For those who people who breathe more through the mouth, we also want to give pressure through the mouth. So we give a full mask, and if the patient is feeling claustrophobic, we give something called as a nasal pillow. A lot of masks are available, gel masks, which are very comfortable wearing them. Really lot of advancements coming in the sizes of the machine, comfort of the sound of the machine coming down. Philips, Resmed, and a lot of other companies, and the new company coming from Make in India campaign also. So we can expect the prices of these machines also coming down in future. So this is what we look at, and we try to adjust based on the complaints report. We study the report and counsel the patient what changes they need to make it more comfortable. And we also ask the patient to use a humidifier along with it so that the nose doesn't go dry. So slowly the patient will start feeling better. The main thing which they see is the daytime sleepiness is gone. They feel motivated. They don't feel lethargic. They participate in activities or their office hours. They participate with full energy and concentration. This is what we get the feedback from these patients. And slowly the hypertension or diabetes or weight, they slowly start to set in back, because if these things are not controlled, the eventual complications, which I already mentioned, is a stroke. Patients can have stroke, cerebrovascular attack, and the patients can have arrhythmia or coronary artery, or what we call it as a heart attack, because a simple problem which has been neglected for decades led to all complications and organ damages. And so this is how we can prevent primarily many of the conditions like cerebrovascular attack, coronary artery disease, diabetes, or hypertension by just recognizing this condition called as obstructive sleep apnea. And a simple study called as a sleep study, which can be done at home or in the hospital under the supervision of a technician, and using this machine or having a correctable reversible risk factors and getting them operated is also leading to complete cure of this condition called obstructive sleep apnea. So thank you so much for this uh, uh, time, and I hope you all got an awareness of this condition on this World Sleep Study that is today. So we hope to come back with many other programs like this on sleep physiology and many other sleep conditions